Can you go to the next one? Okay. Now, this lady here has a infection for 10 years, and it has sinus tracts. Next slide. And she wanted it cut off, so we cut the foot off. And you can see that if we slice it down the middle, what's on the inside? Next slide. So you have this infection that is eating up the whole foot and working up the ankle there. And next slide. The gritty, sandy material is in the lower half called a sulfur granule. And where the neutrophils on the top half meet the edge of the sulfur granule, next slide on high power, you can see the club-like projections of the Splendor-Hopely phenomenon. So what type of infection is this called? Anybody in the audience?
Shout it out.
Madura foot. Very good. Okay, Madura foot mycetoma next. And this has two causes. So your job is to figure out the pathogen. It's either a soil bacteria, next. And those bacteria include the three soil bacteria, Nocardia, Actino, and Strepto. And then next is the fungi. And for your board question, the most common cause of mycetoma acquired in the US, which is what this lady had in Florida, is Cedosporium apiospermium. And then the list of fungi is very long, but that's just one example of a fungi. Next. And you can keep going. Traumatic inoculation and the male-female ratio and the age, and then the treatment is antibiotics, antifungal surgery. And this was so far replacing normal tissue, it would never be normal. So that's why she opted for amputation. Next slide. Okay, so let's give you three locations that actinomycosis is most likely to be found. This is called lumpy jaw. It occurs in horses, cows, and humans. It started in a molar root, even though she was edentulous. Next. She had it cut off, and they found sulfur granules with gram-positive filamentous rods, and it came right back, and then we gave her antibiotics, and it took care of it. Usually we give amoxicillin next for 6 months to a year. If you grow actino on a blood auger, you might see these white colonies that actually look like a molar tooth. Next. So if you can click on one after the other, this is the summary of this actino of the jaw and the sulfur granules, the molar tooth, polymicrobial infection. You can use the amoxicillin and occasionally doxycycline. Next. Okay, the other big location besides the lungs is, this is a board question, and this lady came into Moffitt with a big abdomen getting larger over several months. They scanned her and they find holes in her liver, and her uterus is large. So they go in to open her up, and they try to debride what they think is metastatic ovarian cancer, except it's not cancer. This is actino, and it's in the liver. Next. It's in the uterus, and the key point here is actinomycoses are normal flora of the GYN flora. And if you place an IUD into the uterus, you now have a foreign body, and that can then grow the actino into the uterus. Now, obviously, this is very rare, but it does occur. So the IUD was the tick ball for the actino to go invasive, and it's replacing the fallopian tube, the ovaries, and then spreading to the liver, going in a clockwise fashion. Next. And this was the ovaries. Next. And there is the next case. You get one case in the world of ID of this once every 5 years. And it's the first case I ever came across as a resident rounding with the ID team at the VA James A. Haley Nursing Home. And they had a case of this, but not this case. And this is a verrucous cauliflower lesion, usually in people walking barefooted, and they get a puncture wound, and this fungus spreads up the leg. Next. Notice how verrucous cauliflower it is. Next. And it goes up the leg. Next. And up the leg. Next. It can be hyperpigmented as opposed to verrucous. Next. And here's the VA patient, his arm, and we biopsied it. It was there for 4 years. Look at this. That's the epidermis way down into the dermis, called pseudoepitheliomatous hyperplasia. That word means fungus usually. A microabscess in the right lower corner. And for your board question, the next slide is, there it is. The sclerotic body, copper penny, that's the diagnosis right there, seeing that thing in the middle, okay? So what is this? Any guess from the audience? Rare, once every 5 years?
Telleromyces.
Close, very good. Next. Chromoblastomycosis. So if you take the word blasto and you add chromo on it, chrome as in colorful. Next, you can click through these quickly. So chronic, traumatic, pseudoepitheliomatous, medlar bodies, sclerotic bodies, and then the fungi's name are listed there. You've never heard of them, but that is a syndromic diagnosis called chromoblastomycosis. Next. Okay, this is the cousin of chromoblastomycosis. This is called lobomycosis, not because lobo means wolf in Spanish, but because the guy's name is Dr. Loboi. And it's smooth, and it is also verrucous, and it's found in humans and dolphins. The fish, dolphin, the mammal can get it as well. Next. Okay, next syndromic diagnosis, cutaneous mycoses. This lady has a history of melanoma resected from her upper thigh, which is the crevice there. The mons pubis is down at the bottom. So in her inner thigh, she's got this big ulcer that's about 4 inches wide. She was putting plants in her lap while she was working in her garden, and obviously something must have punctured her leg, and it inoculated it, and it's a non-specific ulcer. You cannot tell what this is. It could be anything. So they biopsy it. Next. And there's the key point. We have a septated hyphae, and the wall of the septated hyphae has melanin in it. So who would like to give us a syndromic diagnosis?
Aspergillus niger.
Good. That's a microbial diagnosis, but the syndromic
diagnosis.
Yes. So here's the key. If Aspergillus is a hyalohyphomycosis, if you want to say it's in that family, HALO, hyalohyphomycosis, that is the non-pigmented fungi example. What would be the pigmented fungi's name if you change the hyalo and put something else in it? Does that help? Blank hyphomycosis. Fill in the blank, and it's not hyalo.
Phaeohyphomycosis.
Thank you. You're right. Next. Okay, itraconazole back then, which could be used as well as Posavori, shrunk it down 4 weeks later, and then it was gone after 3 months. Next. So phaeohyphomycosis is a syndrome, and the fungi on the right are the cause. The most famous ones are Curvularia, Alternaria, and Exophyala, and a bunch of others, and even Cetosporium prolificans is in the phaeohyphomycosis family. Next. So if you can click through these quickly, this is the dark pigmented fungi in the treatment. Next. Okay, you'll get one of these cases once every 30 years, but get ready, it's on the boards. You're healthy, you're working in your yard, something stuck you, you get this chronic granulomatous stuff for several months. Next. And you biopsy it, lots of neutrophils, you keep looking in there. Next. under the high power, there's a little splinter there on the right piece of wood, and then there's granulomas all over. You still don't have the bug. Next. Now we got the bug. It looks like a space invader and an alien creature with 5 lobes to it. Next. And this is called Sporotrichosis. And guess what kind of fungus it is? It's not a fungus. It's actually an algae. It's a plant. So it's Prototheca wickerhami, and it's treated with antifungals. Next. All right, now we get into the endemic mycoses, and if I give you no history, well, let me give you history. The guy was messing around with sphagnum moss, which hangs out of cypress trees, working in his yard, and he got a nick at the tip of his finger, and now it's spreading up his arm. Everybody probably in the room knows what this is. So anybody want to guess?
Sporotrichosis.
Right, so this is actually the syndromic diagnosis is called a nodular lymphangitis, with the top of the list being sporotrichosis. Next. And here is the dimorphic variety of sporo. It's not really endemic to one area, but it's everywhere, but it is dimorphic. This is the yeast phase. So when you look under the microscope, you want to see these cigar bodies, boxcars inside a macrophage. Next. And there's the mold phase. So it is dimorphic. Nothing interesting about the mold phase, but that's what it is. Next. And you can get verrucous lesions. Next. It likes to form up the lymphatics as the key point. Next. You can get these big ulcers from it. Next. And if you're HIV or immune suppressed, it can disseminate it. You could inhale it and you get these little pimples, pustules everywhere. Next. And then there's the cigar bodies and there's your ulcer. So that's the typical type of board question. Next. Now, this is an old slide, but I want to point out that before itraconazole was even FDA approved, my father had this working in his nursery, and guess what he was given? Potassium iodide. And you give it in drops and slowly increase the dose. And then, of course, itraconazole took over. And then if itraconazole is usually the drug of choice, and some of the other azoles, terbinafine works, but not as well. Next. Now, this is the syndromic diagnosis because sporotrichosis is at the top of the list, but the other things that give you a nodular lymphangitis are the nocardias, the Mycobacterium marinum, rapid growers, tularemia, and leishmania. So that is your syndromic differential of this kind of lesion. Next. Okay, this lady comes to Moffitt and she has pimple-looking lesions on her legs. She's got CLL. She's not neutropenic. She is lymphopenic. Next. And we biopsied one of these little lesions on the knee. Next. And this is a different patient, but it's the same bug. And I want to illustrate some lesions may have a central umbilication, which mimics molluscum contagiosum. So that's an important derm point, your differential of molluscum-like lesions. Next. And there it is, the yeast form in a GMS stain showing you a narrow-based budding yeast. This is not a dimorphic fungus, but what do you think a CLL patient would have that is not a surprise for her to have this yeast infection? So what do you think? Narrow-based bud. Opposite of a broad-based bud. Anybody?
No,
Crypto?
Correct. Very good. She had primary cutaneous crypto. We tapped her. She did not have it in the CNS. She did have some lung nodules, and we treated her as primary cutaneous, but it could have disseminated from her lung, but never made it to the CNS. This is a CSF India ink with the capsule and the narrow-based bud, as you see there. Next. There's a beautiful India ink high power with the narrow base bud and the capsule. Next. Here's another beautiful India ink picture of the same thing. Next. Crypto colonies tend to be very creamy-like, as you can see there. That's pretty gooey looking. Next. And this is a cryptococcoma. You can cut them out and potentially be cured. Nowadays, if you have a crypto case, there's another cryptococcoma. You want to know which species it is, and we'll get to that in a minute. Next. So here's in the brain with the crypto in the tissue, and you can clearly see a bunch of yeast, and some have a narrow base bud with a capsule. Next. There's the brain. It likes the base of the brain, so it's the most common cause of chronic meningitis in the United States, which means triad of base of brain mostly involved, but it could be diffuse. Cranial nerve palsy, and more than 4 weeks of symptoms. TB is the world's most common cause, but in the US, crypto is #1, and it's #2 in the world, and it can mess with your ventricles as well. Next. So chronic meningitis, the #1 is TB, #2 is crypto, and don't forget coccidioidomycosis, and then, of course, the sarcoid, and the list goes on and on. Next. So crypto, we know the risk factors, but we're going to talk about unique risk factors coming up next. And this is the bug that is relatively new in the last 10, 15 years. Besides cryptoneoformans, we have a new one on the block, which most of you have heard of, if not all of you, gaddii. This could affect, quote, normal, healthy people with a CD4 normal non-HIV. And it loves to disseminate from the lung to the brain to other parts of the body. And does anybody know what is the unique immunodeficiency you need to look for with somebody with disseminated cryptogaddii who has no cancer, no HIV, a normal CD4? What kind of immunodeficiency do you want to look for on your board question? Anybody? This is a hard question. Okay, nobody. Okay, next. Here it is. Yeah, autoantibodies against GM-CSF. Okay, so you want to look for autoantibodies against GM-CSF, and if they find that's present, you want to give the patient something like Rituxan to knock out the cells making the autoantibody. Of course, ID doesn't do that. Someone else will have to do it, usually. But you, of course, treat the cryptogaddii. So remember this. You may be having someone making autoantibodies. And by the way, for your boards, if you're making autoantibodies to GM-CSF, you're predisposed to not only crypto, but also nocardia. And it's also associated with a non-infectious disease that does show up on your boards. And you know what that's called? Pulmonary alveolar proteinosis. And guess what those people get treated with? Steroids. And then what do you think they get? Nocardia disseminating from their lungs to their brain. So remember that for your board questions for autoantibodies to GM-CSF. Next. So I love the history of cryptogaddii because even though it's not endemic, they discovered it in the US, North America, on the Vancouver, Seattle area. And as they kept looking, they found it all along the West Coast, and they thought it was only over there. Next. And all of a sudden, the CDC did a great study on crypto around the world gaddii, and noticed the Australia, Asia, the Eastern Asia type is the same on the west coast of the US, but it is not crossing the Mississippi River yet. Next. And you inhale it, and there it is on the west coast. This is an old CDC slide before they knew it was everywhere. And they did associate it more with eucalyptus trees, which koala bears like to eat, but it could be anywhere in the environment. You inhale it. Next. Now, notice this. We worked with the CDC because we got involved with them, and we said, we got a guy from Pasco County who came to Moffitt with a leg mass. They thought he had a sarcoma. And when we worked him up, they opened him up. There's no sarcoma in his leg. He's totally healthy, normal CD4. And we tap him and he's got cryptococcosis meningitis, the whole 9 yards. So that little black circle is our case. One of our fellows in Polk County reports the second case in the red triangle. And then the CDC said, well, let's do a joint publication. And they threw in all their other cases east of the Mississippi. And this was a quick little letter to emerging infectious about cryptococcosis is now east of the Mississippi. And that's the whole case. And the whole story is written in that little letter. Next. And that's the CDC affiliation looking for all that. Next. So that is the story of cryptococcosis and cryptoneoformans. And I'm not getting into all the treatment, and it's not a dimorphic fungus. So I threw it in just because I like the fact of the geography and history of it. So when you go in a cave, there are lots of bats and birds in there. So what's the number one bug in caves that you all know of, whether you're in Cancun or in Kentucky or whatever? So anybody want to say the word?
Histo.
Thank you. Next. Okay, so there's all the birds. They may or may not be bats. Next. There is, now if you go in a cave and you suddenly within 24 hours are hypoxic and your lung looks like this, you inhaled such a massive antigen load that we treat you with steroids and we don't necessarily treat you for histo. But that's a unique, rare pneumonitis from inhaling tons of histo in your body, an immune competent person. Next. As you were hiking, you forgot to see this sign. So histo, keep out. Next. And histo likes to affect, just like blastococci, paracocci, your mouth, your nose. So you could see things that look like cancer on your tongue, around your nose, could be an ulcer. Your lung X-ray CAT scan is sort of non-specific. It could look like anything. Next. Now, this case, I have a second case, by the way, at Moffitt, and we had one years ago. Every time this 30-year-old lady bends over, she feels like she's going to pass out, and her arms and head are swollen. So what's her diagnosis? Arms. Huh?
SVC syndrome.
You're correct. Excellent. So she has, and it's basically a normal X-ray, she has superior vena cava syndrome due to fibrosing mediastinitis. So the number one cause of fibrosing mediastinitis is histo, but of course Hodgkin's, TB, and other fungi can do it. But if you look closely, in her superior vena cava is a nitinol stent placed in Arizona, because once it's fibrotic, you can't do anything about it. Next. Now, here's the dilated blood vessels of superior vena cava syndrome. Next. Now, here's the key point, very important. Excuse me. If you have a large mass in your mediastinum, it's usually, if it's an infection, histo, and it's crushing either the superior vena cava. We had a case crushing the main stem bronchus, and it could even be crushing the esophagus, causing symptoms. And you want to give these people steroids plus itraconazole. Steroids get rid of inflammation, itra to kill the fungus. But this is not fibrosed yet. It's still in the large granulomatous phase, and it will get better real quickly with the steroids and then slowly with the itraconazole. So you have to decide, is it totally fibrosed, or is it a little bit of fibrosis and a little bit of granuloma, or is it all granuloma? Next. So here's histo. It could mimic TB by being somewhat small, but they're not as small as a millet seed, although some of them are. So that's a great mimicker. Next. This is a histoplasmoma. Any nodule could look like that. All the fungi. Next. This is an AIDS patient with disseminated histo. And then what could you do with his peripheral blood if you wanted to make the diagnosis quickly in an AIDS patient with suspected disseminated histo? What would you do with his peripheral blood? Anybody? You would spin it down and look at the buffy coat and look for a macrophage full of histo. That's how they used to diagnose it real early in the early phases of HIV. Next. Okay, so histo can mimic syphilis with a papulosquamous rash. So there it is. Next. And then when you biopsy it, if the CD4 is over 200, you may see granulomas. If it's less than 200, you won't see granulomas. Next. And there's the budding yeast. There's nothing specific about the neck of the yeast, but the size tends to be relatively smaller than all the other dimorphic fungi. So usually a good pathologist can say that's histo and not crypto or blasto, but sometimes they can't. Okay, so, but a good one can. Next. So this is the Gamori methionamine silver stain, which clearly sees the budding yeast. Next. Here is the PAS stain, which also sees the yeast. Next. Here is the GMS stain, which is better stain to pick up fungus in the cell wall, as you see. Next. Here are H&Es, gram stains, Wright stains. They all can see the histo, usually in a macrophage. Next. And here is an interesting feature. Histo does not have a capsule, but it looks like it does, and that's called a staining artifact. And notice it's oval to round, and it's small, 2 to 4 microns. Usually nothing is that small in the world of blastococci and all the rest. Next. So yeah, there it is. So if you want to see what it looks like, it's nothing spectacular, but that's the color on the front and the reverse side. Next. And then this is the buffy coat, which I was telling you about, looking for the macrophage on the buffy coat. After you spin the blood down, you may pick up histo like this. Next. This is histo in a liver. There's a different species of histo in Africa where this case was, and the liver is surrounding it, but the yeast and the inside are small, and it's a histogranuloma. Next. And by the way, I've had 3 cases referred to me, my ophthalmologist, of 20-year-old college students at USF, and they wind up with one eye having historetinitis, and the theory is they picked it up from their mother in utero, or they got it as a kid, and now they have histo presenting as a retinitis. They're normal, immune competent, and we give them steroids and itraconazole. So be on the lookout for these weird presentations. Unique. Next. As you know, it's the Mississippi, Ohio River Valley area. I used to say it's not in Florida, but apparently it's in the caves of the Panhandle. Next. And they're saying that it might be wider spread than we actually think. Next. And here's the CDC range. Now, I told you there's other histo outside of the US. So you see it in Central South America, Sub-Saharan Africa, parts of Asia, Europe, Australia. Next. And you inhale it, the bats, of course, and the other birds. You want to think about that, but most people don't have that history. Next. And this is a sad case. If you ever go to Dominican Republic, these guys were told to clean out this tunnel in a dam that was closed for 30 years. Nobody gave them a mask. The bat guano is 1 meter deep. They're shoveling this stuff in a confined area, and 3 of them die, 6 get intubated, 9 are in the ICU. So you don't want to be shoveling histo bird manure with no mask on. That's asking for disaster. Next. Now, I told you the most common one is capsulatum, but in Africa, there's one called duboisii, and it likes to go to skin and bone, and the Middle East has its own. You don't really need to know the species, and we treat them fairly similar, but there are different species, as you can see, or at least varieties. Next. Okay, now, your dog, your cat, especially dogs sniffing around or hunting with somebody or whatever, they also get histo. But if any question ever occurs where a man or a woman and their dog gets a fungal infection, the board question is always going to be blasto. But histoblastococcus can infect your dog, whether you're with them or not, sniffing in the ground and all that stuff. So there's histo in animals. Next. All right, the next fungus. This one, again, likes your nose and mouth and could be anywhere, but this one's verrucous. Next. It can be ulcerative and mimic cancer. So whenever they think it's cancer and it's not, you want to think of this bug. It's classic. Okay, next. Here it is, the verrucous. Next. Again, another verrucous. Next. Another verrucous. Next. This is more of an ulcer. Next. Now, here's the key. This one loves to cause big hilar fullness, as you can see on the right, and the nodules tend to be much larger than the other nodules. They call them cannonballs. They're so big. Next. And then, of course, everybody in the audience hopefully will guess this. What is the one with broad-based bud and it all begins with B?
Blasto.
Right, thank you. So there's all your blasto with the broad-based bud. Next. And more. Next. And there's a nice little review of the locations, the head and neck, the skin, the lungs, the hilum. Next. By the way, blasto likes the bone, so you're more likely to get osteomyelitis from blasto than histo or cocci. Next. And then it's the same area as the Mississippi Ohio River Valley as histo, but it may go up even further north and east. Next. So these are the CDC slides of blasto, and notice it is in the place we mentioned all the way up into Canada. Notice Africa is the other continent with some blasto, but it's a different species. Next. Now here's the key. So blasto has many different species. Dermatides and Gilchristi are some of the most common. So depending on where you're at, maybe different species. And then they rename some of the blasto in Africa, and they call it Amonsia, but all it is a glorified blasto. So if you ever see Amonsia from South Africa, think of it's in a blasto family. Next. And they are dimorphic, by the way. So remember, the blasto is the dog and the human. There's a story of people going hunting with their dogs. So dogs are sentinels. So that's the board question, more than histococci. And then you're around rivers, lakes, and all those places in the Midwest. And if you're immune suppressed, of course, it can disseminate. And then it can become chronic and mimic a cancer. Next. This is an outbreak, by the way, of Blastogilchristi from canoeing, kayaking down a river, and 90 cases doing some tubing in Wisconsin. So that's a famous outbreak. Keep off the island, blasto. Next. And then here's what it looks like, similar to the histo with the colors. Next. And here's some cases I found, like case reports with a nice differential. Notice how big the consolidation is. The hilum is full, and you may have a ulcer. And then there's your differential, and this turned out to be blasto. Next. And then remember the dog, okay? The dog and the blasto go along on the boards. The answer to the board question is dog gets infected with the human, it's blasto. The sentinel dog. Next. So we're now going out west. And of course, you know where we're going with this. This likes an acidic, dry climate. Next. And it also likes the nose and the head and neck. Next. And the key to this is the spherule with the endospores. Okay, so that they claim that these endospores are not classic yeast for the most part, but nevertheless they look like yeast, and so this would be the endospore in the spherule of this bug, and you all know that this is cocci. Next. So here's a spherule with knots of endospores. Nothing else looks like this. Next. And here it is bursting open, releasing the endospores. Next. And then for your boards, if you have a patient with a dimorphic fungus and they have erythema multiforme, which is what you're looking at, or enodosum, the answer is always coccidioidomycosis. So just remember that for the boards. Next. Here's the same thing. Cocci rashes like enodosum multiform. I don't know why this one's ulcerating or getting keloid or something. Next. Now, here's a great point. Cocci has a unique ability, not all the time, but it can cause a thin-walled cavity. So whenever you see a thin-walled cavity, the most common cause is a squamous cell carcinoma, but the most common infection is cocci, and then, of course, TB and others. Next. So this is the case we published, and we did the whole differential of a thin-walled cavity, and cocci is the key point, but other things can do it, including pneumocystis, by the way. That's a real weird one, and we had a case of that with a thin-walled cavity nodules, echinococcus, and then other fungi and mycobacterium, and even TB. Next. We published the case for two reasons, because of the thin-walled cavity, and the person failed fluconazole, the drug of choice, and we gave the second drug of choice, which was posaconazole, and it worked like a charm. Next. So these are coccidioidomas, just like histo can be a lung nodule, and crypto can. So this is cocci. Next. This one was cut out to rule out cancer, and there's the cavity, and that's the gross specimen. Next. There's the spherule with the endospores, so that's calcifluor at 450 high power spherule endospore. Next. This was really a weird case because the fungi usually stays in the endospore. I call it yeast, but it's not a yeast, but it's in that phase. This one was weird because it's growing in the mold in the patient's lungs. So this thing is showing you endospores with septated hyphae. It's got both of the dimorphic characteristics in the lung, which is not the common scenario. Next. So here's spherules, endospores, different ways of looking at them, even a gram stain looking at the KOH kind of coccymycelium. Next. And these are the arthroconidia, the mold phase. They look like a barrel, so those are pretty classic, with the spherule endospore being what you need to know. Next. And then there's the barrel again on the GMS, the mold phase. Next. And then here's the board question. You want to tell the micro lab there's cocci, more so than histoblasto, because the lab can get infected handling cocci not adequately under a good high quality hood with a mask on. And we had to even give some of our lab people who didn't know it was cocci some fluconazole prophy. So that's a whole board question. Do not tell the lab as soon as you know or think it's cocci. Okay, that's board question. Next. Here it is on the West Coast, and even though they say it's in New York, it's from people who traveled out west. It's still out west. We don't have it yet in our area. Next. By the way, the dust storms in Phoenix are called haboobs, and they're full of cocci. Earthquakes shaking the ground out west can also increase the cocci out there. Next. This is a weird market. I don't know who gave me this picture, but it's the cocci market. I'm not sure how that got its name. Next. Okay, so here's the two coccis. There's immitis and posidacei. They are the, again, look at the bottom, no yeast phase, spherules and tissue, the arthroconidia, valley fever, okay? Next, you can't tell them apart, nor do we treat them differently, but there it is out west. It is in Central South America. It's nowhere else in the world that we know of yet. Next. And if you really want to know the epidemiology, the posidacei is more in the Arizona, Mexico, Texas, South America, and the immitis is more in the California, state of Washington, etc., San Joaquin Valley. Next. So there's the cocci CDC slide showing you the location in the cactus in the desert. Next. Oh, before you go back to that again. This is important. One of our attendings in my era was a Filipino gentleman, And whenever they had IDSA, he wouldn't go to the ID week because he was from the Philippines. And if he inhaled cocci, his genetics would make him higher risk of dissemination. So African-American, Filipino, and there may be some other ones that may have a heritage of, for whatever reason, genetically being more likely to disseminate besides diabetes, pregnant women. So that was interesting. Next. These students are doing a little, housing job in Mexico, and they're stirring up the soil, and 20% test positive for cocci. Next. So here's some case reports of cocci at Moffitt. Of course, they went out west, but here's one that actually had cocci meningitis, and he was getting anti-TNF infliximab, and the cocci was meningitis. That's a whole nightmare problem, and you may need to have lifelong fluconazole. So don't ever get a meningitis case, or you'll be really having to watch him forever. Next, even healthy people. So here's the guy's lungs. It was also in his lungs besides his CSF. Next. And there was the biopsy showing you the histo, the spherule. Sometimes the spherules are empty because they're old. Next. And that was another case. This guy comes to Moffitt with a swollen knee. They want to rule out sarcoma. They open up his joint. They think it looks like all these nodules everywhere, and a non-infectious disease called pigmented villonodular synovitis is what they thought it was. And it turns out that it was cocci. So next. There it is. See the guy's knee, it's all inflamed. There's the cocci spherule right in the middle. Next. Look at the gross. Look how nodular that is, the synovium. That's why they thought it was the pigmented villonodular synovitis. So that's a weird presentation. Next. Okay, here's the board question. Okay, you can read all about it in this CID. Expert opinion, what to do in a cocci exposure in the lab. Be familiar with that, okay? You will get called when cocci is diagnosed. The micro lab may not have known it and then been exposed and may need fluconazole. Next. And then I told you it's a nightmare about CNS, and there it is telling you the same thing. It's a whole article on the controversies of CNS management. Please be aware that it's Nightmare City. Next. Okay, here's a New England Journal of Medicine wanting you to know that this person has an ulcer in the tongue, so it could be histoplasmosis. There's the spherule, so there's a nice quick little in and out, and the guy has HIV, etc., and then he's got cocci. Next. Again, the dogs can get cocci, but the board question, remember, it's going to be blasto. Next. So here's all three of the dimorphics, as you can see there. Histo, cocci, blasto. Next. And this is the CDC lumping them all together. Next. Okay, this is the dimorphic fungus in Central South America. Same thing, verrucous, dimorphic, grows mold, yeast phase. And it could be found in the southern Texas area, but mostly Central South America. Next. And there it is, verrucous looking. Next. Again, same thing. Next. And there's looking like a cancer. Next, in the mouth. Here it is in the liver, affecting the liver. Next. All right, so the board question, if they ever show it, is this: there's nothing looks like this. This looks like an old ship pilot wheel with multiple budding yeast. Next. And there's the budding yeast. Of course, this is paracoccidioidomycosis. You're correct. Next. All right, more.
Spike proteins.
Next. And there you have it, paracoccidioidomycosis brasiliensis, and that's about all you need to know about it, but it may show up on the boards, and I've never seen a case, and I don't know anyone that's had a case. Can anyone chime in who's ever had a case, yes or no?
No.
Nope.
All right, well, it's rare. Okay, next. All right, Somebody mentioned this before, but we're running out of time, but we're in the perfect timing because this is the dimorphic fungus out in Southeast Asia that became popular, or at least notoriety, when HIV started showing up. So this guy's from, I think, Vietnam, and he has HIV and he's immune suppressed and he has a pneumonia. Nothing specific about this x-ray. Next. But remember I told you these umbilicated lesions could be crypto dissemination, and besides molluscum contagiosum and varicella can be, and herpes simplex and monkeypox could be umbilicated. Well, this dimorphic fungus also gives you potentially umbilicated lesions. Next. And here's some more of those lesions. Next. Disseminated. Next. Here it is, the yeast phase. Nothing specific about these yeast in a macrophage, but the mold phase will be on your board picture. Next. Okay, beautiful red mold right in the middle, the mold phase. And of course, whoever mentioned it, or all of you can tell me, what's the name of this one? Hilaromyces, which used to be called Penicillium marneffii. Look at the conidia in the middle. They look just like penicillium, so the name was perfect. Penicillium marneffii, but now it's known as Hilaromyces. Okay, so there's the beautiful red colony, and it looks like a penicillium. Next. And now, okay, so here's the map. You can see the map where out in Asia is Hilaromyces. Now, they do try to tell us that Sporotrichosis is dimorphic, but I don't think it really is, but they're trying to tell us it is. It is dimorphic, but it's not endemic. That's what I meant. I don't think Sporotrichosis is endemic, but I could be wrong. But they're trying to tell us, throw Sporotrichosis in your list besides the histoplasmosis. And then look at Amonciosis. That's the old blasto. It's in South Africa. So there's another name of a dimorphic fungus to keep in your back of your mind. Okay, nice, beautiful map of all the dimorphic endemic fungi. Next. So just to show you how distant or closely related these are, cocci is related to paracocci, which is somewhat related to blastococci. And Hilaromyces, which was a penicillium, is more related to Aspergillus, which makes sense. And then notice Sporotrichosis is way out of there. It's not related to any of them. So there you have the different relationships. Next. So if you get a quick review as looking at these slides, which will be on your boards, the one at the top is trying to tell you about the broad-based blood blasto. The one down below that is the narrow-based bud, and that's trying to tell you more about the crypto. And then the next one down, of course, is the spherules. So we're thinking that could be cocci. However, you have to be careful. These are small yeast, even though they're clumping together, and they're smaller than just about everything. Unfortunately, they're almost the size of a spherule of cocci. And the cocci is in a circle down at the bottom, but the one above the bottom one is histo, and notice they look about the same size as a spherule from cocci. So hopefully the cluster won't throw you off there. Okay, next. So these are diagrams of showing you the cocci barrel and the spherule and the blasto. It's supposed to be a broad-based bud, although it doesn't look like it. Histo is supposed to be small, and the paracocci has multiple daughters. Crypto is not dimorphic, but it's a narrow-based bud, and Candida can look like yeast and germ tubes and pseudohyphae and Aspergillus. Next. And we will stop there because I'm out of time and I'm out of dimorphic fungi. And so thank you for your attention, and I hope that will help you when the boards come around.